they couldn't hear me, so I don't know what's happening. But anyway, what we will do is everything will be all right, and the just saddens me. I like having my students here with me, and but anyway, what we're gonna do is we'll record all this, and you guys will be able to watch it and have some fun with it. So yeah, I hope you guys are doing all right, and don't be too mad. I'd be mad, you guys made the time to make it, and silly internet, I don't get it. I don't know. Let's finish this up here and get this done and get you all on your way. Okay, we just talked there about the reflex arc. It's a good one. You'll definitely see a question on the test there about that one. All right. The basic principles there of the somatic motor pathway. Okay, somatic means body movement. The somatic nervous system includes all voluntary motor pathways outside of the CNS. I like this. Somatic effectors, skeletal muscle. Makes sense, right? Nature of a reflex. We just talked about it there. The reflex arc. Okay, and the reflex there consists of either muscle contraction or even a glandular secretion. However it all works, The autonomic nervous system. Okay, this one here, we're talking, and you guys have seen this there before, and I put this in here, and it's a horrible slide. At some point in time, I'll update it and clean it all up, but the whole idea there, you have the sensory division there that receives the message. Okay, afferent means it's at home, it's coming back to the CNS. Well, sorry, it comes to the PNS. It's got to go through your arm first, all right? And then it goes to the central nervous system, where whether it is just like a reflex arc where it's coming back to the spinal cord, if it's actually going back to the brain for a real life decision or whatever, and then comes back with its response through the PNS to the motor division. Okay, now we're on to an efferent exit nerve. It's going away from the body. Now, if it goes to the somatic nervous here, now I have control over. If I want to move my finger, I'm going to pinch my finger here, which is going to send a message, okay, through my PNS to the CNS, which then makes a decision there that now I can move it. Somatic nervous system, voluntary, right? But then there's also the autonomic nervous system, which is not voluntary at all. And you've got the sympathetic and the parasympathetic nervous system, or the division here. Okay? The sympathetic, okay? This one here is your fight or flight. Okay? So if a bear shows up right now, whatever food you're digesting stops. Anything that is not relevant to life, anything there that is going to impede you from surviving is stopped. So all digestion stops, anything like that. Okay, all of a sudden now adrenaline starts pumping through your veins, your breathing starts to rapidly increase now because we need more oxygen, because we are in peril. There's a chance of dying. So everything is thrown out the window. You are now a superhuman. Okay? And whether you have to fight or flight, run away. Okay? Even if you are not an athlete per se, anybody who is in this particular situation and sympathetic, okay, now you can run 2-3 kilometers, and I mean run. Okay, the parasympathetic, okay, this is called rest and digest. So this is after the bear has, you've outrun the bear, which probably you really can't outrun a bear, but the whole idea there that if the bear has been eliminated and you are going to be okay, now that banana, you can start to digest it again. Okay, rest and digest. There's a nice little movie there. It talks about this. I encourage you guys to see the movie. It's kind of simplified, and I think it deals with the bear as well. So have a look at that. Your somatic nervous system allows conscious and voluntary control of the skeletal muscle. The autonomic nervous system regulates events that are involuntary. Okay, activity of the smooth and cardiac muscles and glands, right? Maintains homeostasis of the organs without conscious effort. And depending upon the nature of the external environment that is threatening you or not threatening you, that will send your body into either sympathetic or parasympathetic. Okay. This is just a nice little snapshot there of the things there, the sympathetic and the parasympathetic. Sympathetic, okay, your pupils dilate. Sorry, they dilate. All right, so you can allow more light in. We don't need saliva to survive, so we use saliva there for digestion. We're not digesting if a bear is chasing us. Your heart rate is accelerated. Dilation of the bronchs. Okay, stopping of peristalsis. There's no need to digest a banana if I'm going to get eaten. All right, conversion of glycogen to glucose. If you're not familiar with this, if we have too much glucose, how do we store glucose in our body? We put it on the shelf and store it as glycogen. But then when we need glucose, when our blood glucose drops and we need it, what happens is your body pulls the glycogen off the shelf, converts it to glucose so that we can use it there in the muscles. All right. As I said there earlier, secretion of adrenaline, noradrenaline there. Okay. And also, interesting enough, we can't pee. Okay, stops the bladder from contraction, doesn't matter, it's not important. Okay, the parasympathetic, rest and digest. I'm not going to go through these. It's basically the opposite. There's your vagus nerve, which we talked about earlier. Ooh, you might see that there next week. All right, there's and it's the opposite. The eyes there, they constrict because we don't need as much light anymore. Your saliva starts to kick in, all these kinds of things. Basically the opposite of this, okay? The sense organs there, sensory reception, okay, enables the body there to respond to stimuli caused by the external environment. There's two categories there. There's general and specific. What we've got here there, receptor response. The receptors there, they respond to stimuli by converting them to nerve impulses. So, you do that, okay, that's an external stimuli, but I can feel that going on. So it's the whole idea of converting a real event into a chemical impulse. Love it. The receptor potential there, the local potential there that develops in a receptor membrane when an adequate stimulus acts on a receptor. These impulses, which are just action potentials, which we've covered, travel over these sensory pathways to the brain or the spinal cord. Adaptation there decreases in receptor potential over time in response to a continuous stimulus. So, I keep doing this. I can feel it, I can feel it, I can feel it. But eventually, if I keep doing this, I'm not going to feel it anymore. Like if there's a bad smell, like, whoa, that's a bad smell when you first smell it. But then after a couple of minutes there or whatever, you just don't smell it anymore because your body's moved on to other stimuli. Okay? Adaptation. Doesn't mean that the smell is gone. It just means there that your body knows it's there, but it's not hurting you in any fashion, or you're just moving on, okay, to other more important stimuli. The distribution of receptors there for special senses, of course, of smell, taste, vision, hearing, equilibrium into localized areas, okay, even complex organs there. The general sense of organs, somatic senses, are these microscopic there receptors there, widely distributed throughout the body, okay? And there's even some stuff in here as well, if you guys wanted to see all that. What have we got? And you see here, let's bring this up here. And sensations there produced by the Why isn't that allowing me to move? There we go. Sensations there produced by the receptors or general sense organs are often called somatic senses. And the distribution of general sense receptors is not all uniform in all areas. It can be different anywhere. Okay. The general sense receptors, and I thought that this slide here was really neat. Again, it comes right from your textbook. This is your skin, okay, and this is your epidermis. This is your dermis under here. These are your what we call your dermal papillae. We'll get in there. We do the integumentary system, I think week 11, I think. And you'll see there that you do have these nerves coming up through the dermis. Okay, the epidermis there is basically dead. It's dead skin. The skin, the cuboidal cells, they start emanating there from this basement protein here. It's called the stratum basale. Okay, and as these cells grow, they get pushed up and pushed up and pushed up, and eventually there's a point in time where they become keratinized, hardened, crusty, dry, waterproof, which is what the skin is. Okay, and is it 100% waterproof? No, we can let water out, but generally it's waterproof there, so bacteria, bugs, fungi can't get in. But the whole point of this, these general sense receptors there, you'll see these neurons that are wrapped around a hair root, which is why we can feel I'm pulling on the hair, because there's nerves there. If you touch something, like put your finger onto the desktop, I can feel the desktop. But are you really feeling the desktop? Well, have a look at your epidermis here. There are nerve endings, but they are not anywhere close to the surface of the skin. All right, they are there. They get into the epidermis a little bit, but really when you feel anything, you're really not feeling it per se. You're feeling the pressure of the epidermis being pushed, or pressure of the epidermis against these nerves here. And I thought it was quite interesting there to note. Okay, so small section, a cross section there of the skin showing location of several types of general sense receptors. I just thought that was interesting. Just my opinion. We're almost done here, and I know it's a lot. It really is. And some of the things there we'll hit. A lot of the things there we probably won't hit there. But the classification of receptors there by location. We have proprioceptors there, special types of visceral receptors there. Please follow up in the book. Have a read, okay? Because there's no way that I can cover everything in a 2-hour, 20-minute, 30-minute lecture. It's impossible. So please have a read of the book there. Mainly this chapter here is 20 and 21. Probably the first couple pages there of 21 for sure, okay? The location there, limited to skeletal muscles, joint capsules, tendons, provides information on body movement, orientation, space, muscle stretch. There are two types here. There's tonic and phasic. Tonic, the firing of a non-adapting tonic proprioceptor allows us to locate our arm, hand, foot at rest without having to look. Interesting. Where is my hand? Where is my hand? Okay, I know where it is. It's, and that's what this is, what we call a tonic proprioceptor. We've got phasic. Okay, these are rapidly adapting receptors there that permit us to feel the changing position of our body parts during continuous movement. So I know exactly where my arms, and you see how, and I know exactly where they are. I know where they are in three-dimensional space while they're moving, which is very important because we don't want to break a finger. We want to know where we are in 3D at all time. The classification of receptors there by stimulus. We've got mechanical receptors. We've got chemoreceptors, thermoreceptors, nociceptors, which are activated there by intense stimuli that may damage tissue. Okay, pain. All right, photoreceptors there, of course, the eye. Okay, where it'll dilate or contract depending upon the amount of light. And osmoreceptors Interesting. Which are concentrated there in the hypothalamus. Has to do with water. Interesting. Makes you thirsty. And this is the last part here. Here we talk a little bit about EEG. And this is actually taken there from the lab. We don't do we do this there in the lab. And I hope you guys enjoyed your lab experience there. I understand that, and I'm doing another class, the lab as well, and I get that it's a different machine, it's a different language, the protocol is kind of long and convoluted, but the week one, the lab one there, honestly, if we all knew what we were doing, you guys would be in and out in 10 minutes. But it's new, and we take our time there for the first lab. And wait, I'll be posting their lab 2 there, hopefully there tomorrow, Friday, for next week for my Group A's, and then Group B's there the week after. But the electroencephalography, EEG, this is, wait until you see yours. We strap you, we get the electrodes, okay? You got one there and one in the temporal. And we don't do as complex as this, but we have 2 or 3 electrodes there that we strap you up to. And yeah, you'll see your alpha, beta waves, and it's really, really, really neat. This records there the electric potentials in the surface of the scalp, okay? Your skin has a conductive element to it. Skin conductivity, okay? What tissues there does this potential have to pass through to reach the electrodes? The clinical purposes, diagnostic testing, of course, epilepsy, which is seizures. We'll talk about these. Narcolepsy there has to do with sleeping. Brain activity, brain injury, or lack of activity, okay? When you're talking there with strokes, parts of the brain there can become inactive, which will then affect motor, reasoning, sensory, all these kinds of things. Drug intoxication, as we already stated there earlier, that drugs like nicotine and alcohol, these can enter into the brain. Alzheimer's disease, okay, that's another one there, some psychoses. The process there, in a proper clinical setting there, you'd be looking at between 16 and 25 electrodes there that we attach to the brain. And then we do tests, okay, breathing, strobe lights, math problems, and then we can see what parts of the brain are active regarding adding and subtracting. We can see what parts of the brain are involved in breathing regulation. Really neat. And you guys will do this there in the lab. It's awesome. Factors affecting EEG recording there: hypoglycemia, bright flashing lights. When we do our EEG, we tend to, this is where we have the massage tables. We set them all up in the lab. We turn the lights on low because we don't want that extra stimuli. All right? Because if you're doing an EEG with music playing, there's a TV over there, and you got a Big Mac that just smells so yummy. You know, you've got all these different senses. You don't really know. Your brain's going to look like a roller coaster with all the lights. And we don't want that. We want to isolate, you know. So when you use an EEG, it should be quiet, kind of dark. We want to limit the amount of external stimuli. Funny enough, hairspray, gel, and conditioner. These can screw up there the electrodes. Eye movement, muscle movement. You guys noticed there when you guys had your finger pulse on there. Okay, and when you're sitting there, you get a nice little bloop, bloop, bloop. But then when you take the finger pulse on it, what happened? It went all like this crazy, right? So we want to limit all these kinds of things, and yeah, have some fun with these. When we're talking like a normal EEG as opposed to a seizure, okay, you can definitely see what's happening here. Different classifications of epilepsy are based on location, duration, and severity of these changes in the brain. Okay, like a normal EEG, there's a moderate rise and fall of voltage, okay, in various parts of the brain. And you see it's fairly consistent. Looking very good. But in a seizure situation there, manifestation there of these explosions, okay, in size, frequency. And that's how we know what's going on. And yeah, it's seizures are a bad one for sure. Types of epilepsy there, we've got partial and general there. Partial involves just a portion of the brain. We've got simple and complex. All right. Where simple is in a repetitive movement of fingers, hands, subject is awake. Okay, so the patient is awake, but they can't stop moving a hand or a foot or a finger. Okay, there's complex, which is repetitive movement of action, waving, opening cupboards. Subject is not aware of this activity, so you're actually doing things almost on an unconscious level. Absence, grand mal seizure as opposed to a petit mal seizure. Okay, different. This is of the more serious nature. Stopping of motor activity, usually staring for about 30 seconds. Subject is not aware of the activity. So it's almost like the subject has lost time. Okay, doesn't remember anything there from before or during there. And there's actually a name for it there. Okay, there's the amnesia. We have what's called a tonic, okay, which is grand mal, contraction of all skeletal muscles. So the whole body is basically in a convulsing state, okay, and where the body can actually turn into like a stiff board, and you have all muscle contractions, and is very, very dangerous. Okay. Examples of nerve damage here. Going back into the plexus there, we can have cervical plexus there. There's your phrenic nerve, breathing muscles damage there. So something now, you damage that. Now your ability there to breathe regularly, okay, on an unconscious level, there's a problem. Okay. Brachial plexus there, damage there to axillary nerve, and damage there to the medial nerve there. The lumbosacral, your lower lumbar, absolutely. Sciatica. Sciatica is the pinching of a nerve there, goes down the leg. Very painful. I don't know if anyone knows anybody with sciatica. I know a couple of people there with them, and it's one of the worst things ever. It just doesn't stop. Yeah, it's a bad one. And the last slide there of the day, whew, you're probably going like this. This is great. The more about nerve damage there, destruction of brain tissue. Okay, I like this, ischemic attack. Love that word, ischemic. Cerebral palsy is another one there when we're dealing with nerve damage. Dementia, Alzheimer's, Huntington's disease. The book talks about these. Seizure disorders there. We just talked about petit mal and grand mal. Multiple sclerosis. I think you guys have seen this there before. The myelin sheaths are damaged. And again, it's basically the inability there for this saltatory conduction, and which definitely affects motor movement and that kind of stuff. That is what we got. I totally apologize. I missed you guys. Sorry there, my knee gave me trouble. I apologize there for the internet. I don't know what's going on. I'm going to give Rogers again. I'm going to give him a buzz right now and give him trouble. But like they're really going to do anything anyway. But I hope you guys are doing well. Next week, just to close it off, your test. I'll send an announcement out about all this there. There's no class there next week. Your test will be online on Blackboard. It should be about 60, 70 questions with some diagrams, and yes, there will be some specific ones, but honestly, I'm looking for the major concepts, and I'm not here to take you guys down. I'm looking for a class average of 80, 85, 90. Let's go. All right. So you guys have any questions, let me know. Other than that, Lab 2 will be posted there tomorrow for next week. I'll send an announcement out there about your test 1. And I think you guys are in good shape. So let me know if I've missed anything. Everything kind of looks in order except for the silly internet. But I'll post these labs there I'll post the videos. I might post them there to Blackboard or YouTube. I'll let you guys know in 2 shakes of a lamb's tail. So I hope you guys are doing well. I apologize for everything, and we'll get it all going. You guys are good. Okay? So thank you guys. I'll post this there to Blackboard in 2 shakes of a lamb's tail. Bye-bye, guys.